Pelvic floor pain and the left AIC pattern. Pelvic floor pain cannot be separated from the rest of the system. So you always want to be careful, or I always do. I want to caution people that when you say someone is a pelvic floor patient or any other type of patient in terms of pain, a shoulder patient, you could equally say that that person is a neck patient or a foot patient, because the pain that someone is feeling is just indicating dysfunction in the entire system. They can't be separated. And in regards to pelvic floor pain, I'm making a special case about this because of the nature of what the pelvic floor does for the body. If someone has pelvic floor pain, well, they're probably going to have a tight neck as well. So I could call a pelvic floor patient a neck patient because that neck is not going to be able to move too well because it's being overused for breathing and stabilization. And I'm going to show why that most likely is. So the pelvic floor is on the bottom of the pelvis. So right where my hand is on both sides. The pelvic inlet is on the top. This is the pelvic inlet. This is the pelvic outlet. In the left AIC pattern, here's the left side of the pelvis. It comes forward and out. The right side comes back and in. So here's the position. Now what you see is the inlet on the left gets wider. The inlet on the right gets more narrow. And that actually goes for the whole left side of the body. The left rib cage gets wider. The right rib cage gets more narrow. In general, the left side of the face will be a little bit wider and the right side of the face will be a little more narrow because of the temporal bone. These temporal bones that your ears go through, they're pretty important. They go the same way as the iliums, which is each side of the pelvis. It's the same thing. So the entire left side of the body, face, well, temporal bones, rib cage, and pelvis are all in a state of external rotation. And we also call it an inhalation, a state of inhalation. When you're in a state of inhalation, one side's in a state of inhalation, that side is externally rotated. Okay? On the right side is in a state of exhalation. Everything is being internally rotated. Right ilium, internally rotated in the inlet. Right rib cage, internally rotated. Right temporal bone, internally rotated. Right neck is overactive, right rib cage overactive, tight. So the right side's tight, the left side is loose and externally rotated. And that's the general pattern that you see. State of inhalation on the left, state of exhalation on the right. And that's what happens in the pelvic floor as well. The left pelvic floor muscles are in a state of inhalation, which results in them being descended. When you breathe, this diaphragm, and if you have not studied the diaphragm yet, look up every video on my YouTube about the diaphragm because it all comes back to that left diaphragm. When you inhale, here's the left side, this diaphragm that's in this rib cage, when you inhale, it goes down as the rib cage expands like a pump. So it goes down so that you can fill up with air. And then as you exhale, the diaphragm goes back up and pushes the air out as we return to our normal position, our normal starting position. So remember, we are air manipulating machines. This thorax, this rib cage, and pelvis together allow us to pump. That's what it does. It helps us to pump air. If you can't pump air, you're going to die. So that's the main point of our system, is to pump. It pumps blood, lymph, oxygen, air, all that. Things have to circulate. And when you stop pumping, things start to break down. The body starts to break down. So on the left side, when you inhale, like I just said, when you inhale, the left diaphragm, the respiratory diaphragm moves down. And when you exhale, it goes back up to push the air out. Well, the same thing happens with the left pelvic floor muscle, because you can call it the pelvic diaphragm. On inhalation, it goes down. On exhalation, it goes up. Again, it's not a huge movement, but it should be there. But when your pelvis, that's in a neutral pelvis. That's a pelvis that if you looked at it and you're neutral, and it would be just like this. Now, with every breath you take, it'll go down and up. The problem is when you're in a left AIC pattern, the pelvic outlet does this. it comes closer together. So it squeezes that pelvic floor down. So that's why it's in a state of descension. It's descended, along with the respiratory diaphragm on the left is also positionally descended. So both of these diaphragms on the left side are positioned down when in a state of inhalation. Remember, the left side of the body is in a state of inhalation and the right side's in a state of exhalation. Okay, so the opposite of this situation happens on the right side. The left side is down, the right side is up. And that's with that is with the respiratory diaphragm as well. The problem is that the pelvic floor, the pelvic floor diaphragm is the base, is the foundation off of which our rib cage can expand and our pelvis can expand and even our cranium can expand. If the pelvic floor musculature has been compromised for too long because this pelvic outlet has been mispositioned for too long because of the left AIC patterned pelvis, you can no longer pressurize your body appropriately to breathe with your left diaphragm, and often not your right diaphragm either. And when you're not breathing with either of those diaphragms, that means you can't pressurize the system, so the system can't expand. And if you can't expand, the only thing you can do to get air in, if your rib cage can't expand, and in the back out, everything has to expand. The whole thing has to expand out during inhalation and then come back in during exhalation. If it can't do that, the only thing you can do is start to use your neck to pull your rib cage up. And that's to get air underneath to get air in, because the rib cage has to move somehow to get air in. But the problem is you're not using your pelvic floor diaphragm to pressurize the system, to keep it pressurized. You're deflated. There is no pressure in the system, and when the pressure gradients are no longer there, tension levels skyrocket. Your tension is going to go straight up, and you have to create tension in your pelvic floor muscles, in your quads, in your hamstrings, in your hip flexors, in your lower back, in your neck, to help the system get air in and move when you don't have a system that's pressurized appropriately with the proper muscles. And because the pelvic floor muscles are mispositioned, you're no longer pressurizing properly, which means it's very difficult for people to breathe and get air into the rib cage and have it expand. So over time, the ribs get real tight because you're an extension. Everything gets tight. Your spine comes forward. Your center of mass comes forward. You start to use your neck to pull air up, to pull your rib cage up to get air in. And now you end up in a kind of a forward head posture, and the whole posture is called extension. Now, if it's only on the left side, a left AIC pattern, it's usually not going to be that difficult to resolve. You still need to get that pelvis back on the left. You have to learn how to shift into the left hip. Same muscles as always: left hamstring, left adductor, left glute medius, right glute. Essentially, you have to restabilize the pelvis with the muscles that we can actually control, which are the adductor, the hamstring, the glute medius, and the right glute, and the left abs. Those are the muscles we really have direct control over. We don't really have much control over the pelvic floor muscles. That's why you can't really do much with the pelvic floor muscles. That's why we don't focus on them. The pelvic floor muscles will probably regain their appropriate movement once we have control of the pelvis, but we can only regain control of the pelvis through the bigger muscles, particularly the adductors, the inner thigh muscles, right? So the left adductor, if you don't have a left adductor that's functioning, your left diaphragm will not work, because the left adductor pulls you over to the left side, and until you can get completely to the left side, the left diaphragm can't pressurize properly, and neither can the pelvic floor. The adductor has to pull you there for those muscles, those the pelvic floor diaphragm and the respiratory diaphragm, to regain their function. You have to have an adductor that can put you over onto the left side. If that's not there, you're not going to be using your left pelvic floor diaphragm nor your respiratory diaphragm. So that's kind of normal. I doubt that most people who have pelvic floor pain are a simple left AIC pattern. What you'll generally probably find is people who have pelvic floor pain are probably what we call patho, meaning they have ranges of motion that they shouldn't have. So for example, if a pelvis is forward on the left, that means the hamstring attachment moves further, it moves up. So the hamstring attachment moves up away from the ground. It's starting further back. So if you did a straight leg raise and you lie down on the ground and someone brings your left leg up, it shouldn't get to 90 degrees, and it definitely shouldn't go past 90 degrees. It should stop short of that under normal conditions because your pelvis is not positioned properly. You're in a pattern. So in a left AIC pattern, the leg really should only go to 60, 70 degrees. If it's going, because it's not positioned properly for it to go further. It's a biomechanical impediment. It shouldn't go further. If it does go further, I know this person's in a left, I know their pelvis is forward on one side or both sides, let's just say the left side. If it's forward on the left side, I know that straight leg raise should be limited. If it goes 85, 90, 95, 100, 105, 110, 120, which you do see, you know their pelvis is insanely unstable because they have too much range of motion. And in that case, they are what we call patho. They have, it sounds bad, but they are patho. They have too much range of motion. But what it really means is, and too much range of motion is fine as long as it can be controlled. But I know these people will have uncontrolled range of motion, which means they're going to be tense. Their back is going to be tight. Their hip flexors are going to be way overactive. And a lot of people, especially people who partake in things like yoga and gymnastics, and what they're doing with their bodies encourages that type of flexibility, or maybe they're just born like that, and so they gravitate towards those activities that perhaps they are just hypermobile to begin with. Whatever the reason, they say, look, I have such great range of motion, I'm so flexible, that's great. And then, but I know what's going to happen. The moment I go to their neck, it won't move. They have range of motion everywhere except their neck. Their neck just does not move. You see it all the time. So anytime someone tells me they have pelvic floor pain, I just want to know, what is their straight leg raise? And then I want to test their neck. And if their straight leg raise is already past 90, I know what I'm going to find at the neck. It's going to be tight. There's no way it can't happen. You can't have one without the other. I'm not going to say that. It's going to be exceedingly rare to have a patterned pelvis on one or both sides with a straight leg raise that goes to 90 or beyond, which means they have too much range of motion and they are unstable. It's very rare to find that, but have a neck that's nice and relaxed. I don't know that I've ever found it. So I'll never say it'll never happen, but I just haven't seen it yet in 8 years of doing this. So a pelvic floor patient, you could say, is a neck patient. You could say a neck patient who cannot rotate or side bend, you're probably going to find a very unstable pelvis at the same time. So you can't separate the two. Regardless of where people are feeling the pain, it's a total body issue, and it's still going to be a breathing issue at its core because the breathing muscles influence how we move. So as I was saying, the patho issue is the bigger issue. When someone's pelvis is forward on both sides, so if we call it Pathopec, if someone's pelvis is forward on both sides, that means that pelvic floor on both sides will be squished, descended down. You're generally also going to find a rib cage that's flared on both sides, a lot of extension through the lower back, a lot of hip flexor tension, a lot of lower back tension, and a lot of neck tension. Now, again, the pain can show up anywhere. They might also have a lot of weird symptoms. That's, fight or flight type symptoms because their body's living in a state of tension because they're so unstable. They have to stabilize first. And so when you start to stabilize them, and this is the other problem. I don't like to talk about pathopecs too much because there's so many influences that can create this pathopec. I was one, but it was all coming from up here. Not everyone who's a pathopec has an issue, but they probably will have tight jaw muscles because everything up here tightens. But it doesn't mean they need dental intervention. As they start to restabilize their pelvis, give them hamstrings first, give them adductors first, inner thighs, and abs. That's how you have to start. because we got to get this pelvis out of this position and back into a neutral position, which will require, and not only that, their femurs, their legs will probably be turned out also. So they need hamstrings to pull this pelvis back. They need adductors to pull these thighs in because remember, if you have no adductor, you cannot pressurize your pelvic floor. So hamstrings, adductors, and abs. And depending on, that's how you start them. That's only the beginning. That's why these people take a long time. But again, a lot of the issues that you'll find down here, they're probably going to have neck tension, and you have to figure out what the source of the neck tension is. Has the neck tension changed how their visual system is working, or their teeth are working, or their teeth, has it shifted their jaw at all? All these things, of course, they're not going to be breathing properly. They're not using their diaphragm, so they might be chronically over inhaled. And usually they're very tight, a lot of symptoms, a lot of just their life can be, well, unfortunately, kind of difficult. So there's just so many things to talk about that you really can't cover everything. They're tense. They're tense. But they have to become stable first through the pelvis and with breathing so that they can expand the rib cage before you can really start to bias them on one side or the other. The whole system needs to be detensed. You have to get tension out of the system, but sometimes they are so tight they can't let go. They cannot let go of their back. They can't let go of their hip flexors. You try so many things with them, but the more if you try to change things too quickly, their body fights back and they get more tense, and now they feel worse. So patho-PECs are difficult, and that's why I don't talk about them much, because there's just so much to talk about, and it's so not understood by the average person, nor should it be, because why would you study that? But so my guess is that people with pelvic floor pain will often have a degree of pathology, too much range of motion, but in some area. Often they'll be able to full squat. They'll be able to squat all the way down when they shouldn't be, because I know that their pelvis is forward and their rib cage is up. They shouldn't be able to get to a full squat. They should be restricted. They shouldn't really even be able to touch their toes, but now sometimes they can actually palm the floor. Those are like three of the main tests that you would kind of look at. And when you know they're in a pattern and they should be restricted, but they're not restricted, you know they've become loose and depressurized. And now once you're depressurized and loose, you're unstable and can't expand your rib cage properly. So you're going to be very neck driven and very lower back driven and maybe pelvic floor driven. But the pelvic floor is just dysfunctional. It's not really driving you. It's just painful because of all the other issues going on in the body. So I never treat pelvic floor issues. I treat the pattern that causes pain in the pelvic floor. And it's going to take a while, depending on how much pathology, as we say, is there. The more pathologies that's there, especially when that straight leg raise is well past 90 degrees, good chance it's going to take quite some time. People have to be aware of that. It's not going to be one session. It's not going to be 2 sessions, nor 3 sessions, or 4 sessions. It's going to be more than that. But so that hopefully that will just give an overview of pelvic floor pain and how it's just a symptom of overall dysfunction, overall extension of the system that has become too depressurized. And thus, once you become too depressurized, to move yourself and breathe, you have to tense yourself up. You don't have that normal expansion and relaxation cycle of breathing and movement. You just have expansion and tight, and that's it. And there's no pumping movement going on. Everything is kind of dysfunctional because everything is just so tight. So hopefully that can give a little bit of understanding of pelvic floor pain from a postural restoration. Other people will have, you could probably ask other therapists, and they might have other thoughts on it. I'm not saying I'm the only person that has thoughts on it, but that's just how I look at it. Because I just know if this pelvic floor is depressurized, which it will be if your pelvis is stuck in this position for too long, the neck is going to be overactive. And once the neck is overactive, that neck influences your whole life. So hopefully that is helpful. If you found that video helpful or interesting, could you please like it, share it, subscribe, or give me a comment? Thanks.